Aimee Afable, who's going to be sharing work around We Care About Brooklyn, a social care intervention designed to improve maternal health and well-being. Welcome and thank you.
Thank you, everyone. And it's going to be difficult to follow this this presentation, but I hope to inspire you because I've been inspired as well. So I appreciate the previous two presentations. Okay, I want to acknowledge my colleagues and all the students that worked on this project. My main sort of collaborator, co-partner in this work is Dr. Christina Pardo. She's at Weill Cornell Medical Center. She was originally working with me when she was at Downstate Health Sciences University, which is where I'm at in Brooklyn. So I do want to shout out to her. She was trying to get here today, but she couldn't make it. She's busy being a community advocate as well as an OBGYN. So, it was tough to get her out here. So I also want to acknowledge all my colleagues at Downstate Health Sciences University in Brooklyn, my community partners, Arthur Ashe Institute for Urban Health, Brooklyn Perinatal Network, and I also want to acknowledge the funding that supported this work. I don't have any conflicts of interest. I don't have that slide, so I just want to mention it. Okay, today I want to just talk a little bit about the epidemiology of the maternal health crisis in New York City because this is what motivated the intervention. And then I will talk about the intervention and our design of We Care About Brooklyn, which is a remote community health worker-led precision support intervention which was designed as a potential solution to the crisis in New York City. And then I'd like to share some preliminary results of the pilot evaluation of our intervention, WeCap. Okay, so as many of us, I'm sure you all know, in the United States it has existing maternal health crisis. Among our affluent peers, we have the highest rates of maternal death, and what is really driving the high rates in maternal death are the death rates in Black women, right? And so you could see here, all the way to the right, U.S. Black women have the highest rates of maternal death in comparison to the U.S. white population and as well as the Hispanic population in the U.S. If we look at New York City, the crisis is pronounced. For example, this is the latest data that we have on the Black-white disparity in pregnancy-related death in New York City. So taking data from 2016 to 2020, the Black-white disparity is 6-to-1, right? So, I present definitions here because I'm using interchangeably maternal death, pregnancy-related death, severe maternal morbidity. I want to make sure you just have the definition, and I'm happy to talk about the rates later on. But I want to emphasize that this 6-to-1 disparity is more pronounced. So at the national level or at the state level, it's between 2 and 3-to-1. So it is more pronounced in New York City. If you work in the maternal health space, because maternal deaths is very rare, we often use severe maternal morbidity as a proxy for maternal death. So when we try to examine where are the hot spots in different areas in New York City, we look at severe maternal morbidity, which is considered a near miss to maternal death. Okay, so Central Brooklyn is the epicenter of New York City's maternal health crisis. When you look at the data and the patterns in severe maternal morbidity, here you see several neighborhoods in New York City. Brownsville, East New York, and East Flatbush are all in Central Brooklyn. And if you compare these neighborhoods to all the other areas or neighborhoods across New York City, across the different boroughs, for those that don't know, New York City has 5 boroughs, but these have the highest rates of severe maternal morbidity. They're all located in Central Brooklyn. Central Brooklyn is the catchment area where my university is located in Brooklyn. So that we have a reference point, I also include a more affluent neighborhood in New York City, which is the Upper East Side. I also have the New York City average as well as the US average. So you see here that severe maternal morbidity rates far exceed national, state, as well as, national and New York City averages. In Central Brooklyn, we also have, here we have the slide that shows severe maternal morbidity by country of birth. And I want to emphasize again that really Black immigrant women originating from the Caribbean are the population subgroups that have the highest rates of severe maternal morbidity, and these women and this population is concentrated in central Brooklyn. So we have, just to give you a flavor of the populations that we're working with a highly immigrant population, primarily women of color in central Brooklyn. Okay, so Central Brooklyn is one of 3 neighborhoods in New York City that is classified as historically marginalized, and also a high priority area zone in New York City. It's Central Brooklyn, it's East Harlem, and South Bronx. For decades, they all have had a disproportionate rate of poverty, disease, and mortality. It's pretty well known in New York City that these neighborhoods have been historically disinvested in. And so here you see an example of East Flatbush, which is a neighborhood in central Brooklyn, compared to a neighborhood perhaps 2 miles away, Borough Park. And you see sort of the disparity, both in disparities in severe maternal morbidity. One neighborhood, Borough Park, has a higher proportion of non-Hispanic whites, lower poverty rates, and if you see in East Flatbush, they have a much higher rate of poverty, percent non-Hispanic Black, as well as a higher rate of late or no prenatal care and preterm birth. And again, these are just 2 miles away from each other. Okay, so We Care About Brooklyn was really designed as a way to really try to address this maternal health crisis from a community perspective, right? And so we view this intervention as a potential low-cost solution to the maternal health crisis in New York City, and I'll give you I'm going to talk a little bit about how we came about to designing the intervention. So as we've all been hearing throughout the morning and throughout the day, really what was driving the intervention design or intervention prototype design was the idea that we are serving a very hard to reach population that's very vulnerable, that is dealing with all these unmet social needs. So imagine recent immigrants, they're dealing with financial insecurity, potential housing insecurity, food insecurity, childcare, et cetera. So the intervention was designed with the idea that if we empower women and provide them with enabling resources, we will be able to empower them. They'll feel less stress. They'll be able to prioritize their own health care and ultimately promote continuous engagement in care. The primary outcome of our intervention is postpartum care, although I am not presenting data on that outcome today because it's a little messy. We're using data from the EMR, so we're still sort of cleaning that data, but my focus today is on presenting our secondary outcomes on stress, depressive symptoms, and depressive symptoms. Just want to acknowledge that the theory overall is the Gelberg-Anderson health service utilization theory. Okay, so as I was saying, the idea of WeCAB really builds on a history of community engagement. Here you see photos of all the events that my colleagues and I have participated in over the years. And I want to point to the center of the picture. I don't know if you see the center of the picture of my mouse is. I don't know where the clicker is. This is the women who make up Brooklyn Perinatal Network, which is really the OG in the maternal child health space, advocacy space in New York City. Back in 2018 or so, when I met them, Back in 2018, when I met them, they had this idea of promoting this model that was already present and existed in other parts of the United States, which was called the Pathways Community Hub model. There actually is published evidence of this model. It's basically a community engaged, sort of community-based care coordination program that took off. Many of you might know it already. That took off in other parts of the country, and it's designed to close a loop in pathways, different pathways for social needs, and it has shown to be cost efficient as well as sustainable because it does pay and reimburse for completion of services or closing the loop in care. So back in 2018, I worked with BPN and other community organizations to really lobby local politicians to integrate this sort of idea and concept in our local healthcare space. And so here in 2000, you see the picture at the bottom right, 2020, we actually participated in a New York State legislative debriefing to promote this community-based care coordination model called Pathways Community Hub model. I mean, there's several studies published on it, but there are actually, a cost study was recently published that showed that the Pathways Community Hub model was cost efficient. For every dollar that was spent, they received $4 in return for the investment. So there is some promise there. Okay, so today I'm going to be presenting on the formative phase of how we designed WCAB, in the WCAB intervention. Then I'll talk about the pilot randomized controlled trial results of WCAB, focusing on depressive symptoms and perceived stress. Okay, so it's a complex study that we use to design, a complex approach that we use to design the study. We use a framework called transcreation, which was actually developed by UCSF researchers at Annapolis. But what I liked about this intervention framework is that it places equal value on community assets and expertise as well as scientific evidence, right? And so, I felt it was a framework that really fit into the work that we already were doing in the community. And so from there, we devised a mixed methods formative research, community engaged research approach, which included all these points here. And again, I can't go over all of the different aspects of it, but it basically included a document review of health-related social needs screening tools, qualitative interviews with all of our community partners, and a review of community health worker-led maternal health interventions. Okay, and then I'll jump to that, and you just see on the right, you have sort of the main components of our community health worker-led maternal health precision support intervention. I want to emphasize that it does involve technical skill in digital care coordination using a platform that I haven't heard about yet today, which is called Unite Us. And so that's really, and I'll show you results from the advantages of using that technology in a bit, but it also includes proficiency in client check-in and trust building schedule. So like we heard, throughout the morning, throughout today, developing that rapport and the relationship with our clients was really key to encouraging sort of continuous engagement in care, as well as more promoted receptivity among our clients towards health recommendations and other kinds of urgent warning signs that we also trained our CHWs in. Okay, so some of just again, building on, I want to emphasize on the idea that trust and rapport building was essential to, one, establish a relationship between the CHW and the client, and also so that the client would feel comfortable reaching out to us if they had any questions. So that was, again, really big part of our curriculum. And then the idea of a closed-loop care coordination using Unite Us really address this issue of fragmentation, right? And so you sort of see the quotes here. I'm not going to read both because I don't have time, but one of the quotes that our key informant interviews had was that they talked about having staff that was intelligent, they have to be empathetic, they have to look and see when people's eyes fill with tears and when they get angry, right? So these were things that were communicated to us by our community partners. Okay, and this is our social determinants of health screening tool. We actually developed one specifically for the maternal health population, and we compared it to the other sort of tools that are out there that have been validated already. So the point here is that we actually included novel items that specifically address maternal health needs during the prenatal and postpartum period. Infant supplies is one of them. Okay, here are the results of our randomized control trial. I'm just going to give you, this was conducted with 63 women. We were recruited at Downstate Health. We stratified our sampling by U.S. nativity because a significant portion of our population is immigrant. We collected data on immigrant experience, the perceived stress scale, Ettenberg scale on depressive symptomology, and postpartum care, and these are the methodologies the analytical tools we used. Okay, just so that you all know this, it was a randomized control trial, and here I just have the characteristics between the control and experimental, so there were no significant differences, but you get to see the sort of the diversity of the sample as well. And then results of the WCAB screener. Every 100% of our population screened positive for at least one of our needs, all expressed a need for newborn essentials. And again, the thing on the column, the box on the green really is the data from the Unitas platform. It sort of tells us how many referrals were accepted, how many are open, et cetera. So it was a really great way to sort of take a record of what we were able to fulfill and close a loop in care in. Okay, so here are the final results. Sorry, perceived stress declined before and after the intervention for both foreign-born and U.S.-born, but the difference here is that it's much more pronounced in foreign-born women. Depressive symptoms also went down. And then we also ran a logistic regression predicting likely depressive illness, and we did see a significant odds ratio for that, adjusting for several factors. And we didn't see a significant difference on stress, but we also saw it's trending towards significance. I'm going to skip that. Okay, so sorry, it took so long. Preliminary data suggests that WCAB is associated with a lower risk of depressive symptoms and stress. Our central Brooklyn population appears more vulnerable relative to other U.S. maternal populations, and that could be due to a number of things. It is inconsistent with the healthy immigrant paradox, but again, this is primarily Black women of Caribbean origin, not necessarily Latinx or Latino women. I also want to mention that Downstate, like many other institutions in central Brooklyn, has suffered from longstanding structural inequities that had contributed to fragmented care. So WCAB was developed with the knowledge and experience of the challenges faced by such safety net institutions. And then here I have some limitations. We're still collecting the data. So at this point, the pilot randomized control trial has a small sample size, but hopefully, when we're done with it, we'll be able to retain those results. Thank you.